and you're good to go. Go ahead.
Thank you very much. We appreciate the opportunity, as usual, to contribute to the CCSN webinar series. And judging from the response, I think that this topic is both timely and interesting to a number of folks. So we're pleased to offer it. I'm going to start by introducing our guests. Neither of them probably need very much introduction to the folks on the call, but I'll take just a minute to say that Louise is a health policy consultant who's working with Save Your Skin Foundation. She's a lawyer, and she's been involved in health policy and access advocacy for many years. I won't say how many, Louise. She started her work in the HIV community in the early 90s, and she co-founded the Canadian Treatment Action Council, which has been a long-standing, successful advocacy organization regarding access and quality of care for people living with HIV. Recently, Louise has sort of shifted her focus a little bit into cancer, and she has done a lot of work in that regard. She has also received a bunch of recognition for her work, including an honorary law degree from Queen's University, the Order of Ontario, and 2 Queen Elizabeth II medals. Martine is also an accomplished advocate as Executive Director of Myeloma Canada, one of the leading patient organizations and health charities in the country. She joined that organization in 2018 after a career working in stakeholder relations and public affairs in the innovative pharmaceutical industry, including leading a team of patient engagement professionals in her previous role. So thank you both for participating. We'll get to your insights a little bit later on. Before I get into reviewing what I want to cover, I too just want to make it clear as I go through this process that I am not representing CADTH in this discussion. I'm going to summarize some material that they have put out in terms of a proposal, but I will be interpreting it the best I can, and I want to thank CADTH for sort of working with me on this, but I want to make it absolutely clear that I'm not speaking on their behalf, and if there's any questions or comments about that, I'm happy to deal with it. But the way that I'm going to address this issue today is to give you a little bit of an overview of how the Cancer Drug Implementation Advisory Committee fits within the broader Canadian medication review and approval process. I will take you through my interpretation of the CADTH proposal for transitioning CDIAC from its current home to CADTH. We will follow with a discussion with our 2 panelists, and then open it up to Q&As from the audience. And once again, if you have questions, you can ask them. You can type them out in the question box in the GoToWebinar panel, and I'll address them when the time comes as best we can. So this slide really is to give you the broad overview of how new medicines are reviewed and funded in Canada. You'll see that there are a variety of steps. On the left-hand side of the illustration is the public process, and on the right-hand side of the chart, you'll see is the private process. There are a number of steps in this leading to patient access. I am going to focus my remarks on the public health technology assessment piece and the Canadian Pharmaceutical Alliance piece, which are affected by the work of the CDIAC. So the pCODR process is an established national review program that is run by CADTH, which conducts evidence-informed comparative clinical and cost-effectiveness evaluations of new treatments in Canada. As part of that evaluation, CADTH first undertakes a systematic review of literature. It then engages with clinical and economic panels to conduct assessments of evidence that's submitted by manufacturers primarily. It considers public drug plan, patient and clinician input, and submits its findings to the pCODR Expert Review Committee, which is a multi-stakeholder group of experts that has expertise in considering these kinds of data, and then makes recommendations to all of the public drug plans in Canada except Quebec to assist them in their public reimbursement decision making. They use a fairly detailed deliberative framework within that. The Pan-Canadian Pharmaceutical Alliance is the next step in the process. And what the pCPA does is it takes the recommendations that pCODR and other bodies like it develop and utilizes that in the context of agreement negotiation with innovative pharmaceutical manufacturers relating to new medicines that are currently under consideration for public reimbursement. The pCPA is a process that involves all the public drug plans in Canada, including Quebec. And within that framework, it negotiates with those innovators on behalf of all of those players. The terms are negotiated in the context, the terms that are negotiated in the context of a successful agreement are then used to facilitate public reimbursement deals between the manufacturer and each individual participating. The pCPA terms that are negotiated are a basis for the product listing agreements at the jurisdictional level, but there are other jurisdictional specific circumstances that need to be taken into account, such as formulary design, reimbursed competitors, and other system considerations. So hopefully that gives you a bit of a frame within which to have the rest of this conversation is going to take place. So CDIAC, it's the Cancer Drug Funding and Implementation Advisory Committee. It's a multi-stakeholder advisory body that was created by the Canadian Association of Provincial Cancer Agencies. Its role was really to provide advice about various funding options and the sequencing or place in therapy of medicines that are under consideration for formulary listing. The CDIAC has been in place as part of CAPCA's Cancer Drug Funding Sustainability Initiative since 2016, and it's currently being considered, or its responsibilities are currently being considered by CADTH to be integrated into the pCODR process that I described a little bit earlier. Their process currently, the CDIAC process currently takes about 3 to 4 months, and it usually takes place in parallel with parts of the pCODR review process and parts of the pCPA process, because it's intended to support those activities. Before I get into my summary of the material, I want to just make you aware that CADTH has produced a background document that provides a fairly detailed outline of the proposal. and the key functions that are going to be integrated, that are intended to be integrated into the pCODR process. So there's a consultation document, and I've included the link here as well. CADTH held its own webinar on this subject where it went through in detail the consultation materials, and there's a recording of that webinar that's available, and so the link is here as well. And as Alison said, these slides will be available to you, so you can collect these links after this session. So, as I said, CADTH had a webinar, and they gracefully allowed me to borrow a couple of the slides from that to assist me in making this presentation. So what this slide is a CADTH slide that that just goes through or illustrates the pCODR review process and demonstrates where currently the CDIAC consideration is integrated. So you see that it happens sort of in the process where CDIAC begins its consideration, and then the ultimate recommendation from CDIAC goes to the CAPCA board for its consideration in the context of the PCPA's advice to the public plans. So here's what the proposal is about. It's a summary of what CADTH is suggesting. So there are tasks that CDIAC undertakes that are intended to be embedded into the pCODR review process, the existing pCODR review process. One is consideration of how to integrate new treatments within a given therapeutic area, so in the context of what's currently being funded, and then to examine how a new product would affect existing treatment patterns. So those are that's the sort of core objective. In order to achieve the transition that we've talked about, there are several proposed changes to the current existing processes. So the most significant, from my perspective, is the changes to the pre-submission requirements. So pCODR's pre-submission requirements, where they work with the submitter to sort of get everything organized before the evaluation occurs. Within that context, the CADTH proposal talks about the creation of a provisional algorithm outlining the potential place in therapy for a new medication that's under pCODR review. The algorithm would be developed by CADTH staff, obviously, as new products come in to the same therapeutic area, the old algorithms will have to be altered to account for the new entries. But in any case, the algorithm is provisionally developed by CADTH staff, and then it gets integrated into the review process in a variety of ways. There'll be questions about the algorithm that we pose to the patient and clinicians who are inputting. The algorithm would be shared with the provincial advisory committee, which is the drug plan managers that are involved in the process. It will be shared as well. It will evolve through the process, but it will be shared as well with the clinical review panels that are created to conduct the pCODR evaluation, and of course shared with the PERC, with the expert review committee, as part of its deliberations. And it's also proposed that it would be included in the recommendation, evolved version would be included in the initial recommendation and available for comment to all of the players that are inputting into the process before a final recommendation is made. And of course, the algorithm would then be shared as part of the final recommendation as well. There are a couple of other proposed changes to the pre-submission process. One is to make it mandatory for submitters to notify pCODR of a coming submission as many as 120 days prior to expected marketing authorization from Health Canada. It would also, there was also proposed changes to the sequence of the provincial advisory group and input and a pre-submission meeting that takes place between CADTH and the submitter. And they'll also, as I said, in order to facilitate clinician and patient input into the process, there would be some additional questions to the sort of basic templates that would put in regarding the algorithm into that process. Another proposed change is to enhance the clinical engagement, clinician engagement by a couple of things. One would be to potentially create ad hoc clinical expert panels to provide advice around the algorithm. That may not be necessary for all products, but in any case, there would be surveys of clinicians, active clinicians, looking for their input on the algorithm as well. There would be some revisions to the mandate of the provincial advisory group, which, as I said, is the public plan contribution to the pCODR process. To the clinical guidance panels and to PERC, all around inputting into and providing guidance around what the algorithm should or should not include. In addition, there's a suggestion to expand the Provincial Advisory Committee membership beyond public drug plan officials to include the chair of the ad hoc panels that might be created in the PAG. And finally, as is the case now with CDIAC recommendations, the pCODR process would allow for the CAPCA board to have a review to provide input on the algorithm and examine the recommendation of the algorithm before the final PERC decision. So I hopefully have given you sort of a quick, broad overview of the changes that might be coming as a result of this consultation. And here's an illustrative example of what I've just gone through, where some changes have been made, will be potentially made to the process, and you'll see green bullets that show some of the things that I've just discussed with you. So in terms of the consultation, it's currently underway. The deadline for comments, stakeholder response to the proposals that I've just outlined and that were also outlined in the more thoroughly in the background document and the CADTH webinar, that closes on March 28th. So if you want to have input into that process, by all means, be mindful of that March 28th deadline. Following the receipt of all of the stakeholder input on the proposal, then CADTH is going to go through some internal review of what's been suggested, and they will propose a modified process based on the input received somewhere in the late spring timeframe. At the moment, the intention is to launch the embedded CDIAC process within the pCODR evaluation process around July 1st. However, I just want to make it clear that CADTH has stated quite clearly that that's flexible in the context of what kind of stakeholder input they get, and so if the revisions require further time, they'll take that time. But currently, the intention is to get this new process underway on July 1st. And I should mention too that in the meantime, CDIAC in its current frame is continuing to operate and continuing to provide the advice that it has been doing since 2016 through the CAPCA board, and will continue to do so until the transition is complete. So with that, I think I hopefully have represented the proposal well and properly. And if you have questions, of course, you can ask them. We've got a couple that have come in so far. But before we get to your questions, I'm going to take advantage of having Louise and Martine with us. And let me ask.
Hey, this is Alice and Gerry. Sorry to interrupt real quick. We're just, we seem to have lost Louise on the panelist list, so I'm just trying to get her back on at this time, just so you know.
Okay. So, Martine, it looks like it's, we're going to rely on you to start, and hopefully we'll bring Louise back in when she gets back.
I'm on.
Oh, you are. Good.
Oh, there we go. Okay. Thanks, Louise.
Thanks. Yeah. So, let me ask the two of you first. Tell me a little bit about your experience in the context of CDIAC's sort of evolution, the CAPCA Drug Funding Sustainability Initiative. What's your general sense of how that has evolved, and how do you feel about the concept of moving these mandates into pCODR? So let me start. Maybe Martine, I'll ask you, and then we'll come to Louise.
Sure. Thank you, Jeffrey. I'm extremely happy with this integration of the CDIAC into the pCODR process. I think that the powers at CADTH and CAPCA have listened to the input of many stakeholders, and I'm, generally very pleased with what they're presenting to us now. I mean, we'll talk a little bit later about some of the sort of observations that I would like to make, having been a patient organization who has made a number of submissions, especially recently, and also have worked with clinicians in making their patient submissions. So overall, I'm happy.
Thanks, Martine. And Louise, do you have any comments?
Yes, I do actually. First, I'd like to say thank you very much to CADTH for recognizing the importance of the work that was being done under the old CDIAC model, and for doing what must have been a Herculean task in getting all the funders to agree to move it under CADTH. I know it's very hard to get that many decision makers to agree to anything. So congratulations on that. And I'm also very optimistic about this change because, and and I'm sure Heather Logan, if you're on the call, but I guess perhaps you're not, you of all people will recall that I was certainly one of many vocal opponents to the process that was being undertaken for this kind of work, developing these treatment algorithms under CAPCA. And the reason I was is because there was no transparency in what CAPCA was doing. There was no patient engagement in what CAPCA was doing. And I basically, and many others felt the same, believed that what they were doing was being done in a profoundly unethical way, and certainly didn't meet the basic standards of due process in making such important decisions affecting the lives of patients. So I would really like to say that I'm very delighted that CADTH has taken this on. I understand that it is a huge job. I suspect that we will have lots of bumps in the road as we figure out how this work is best undertaken. It's not going to be perfect jumping out of the gate, I'm sure. But if we all work together and understand each other's perspectives and needs, I think we can come to something that we can all be relatively satisfied with, at least in terms of understanding it, even if we don't agree with every single bit of it.
If I may just add that the openness to stakeholders' input is also very much welcome. As you remember, Louise, and many of the other people on the phone, there was not a lot of discussion that happened when the CAPCA and CDIAC sort of presentation was made about 2 years ago to a number of us. It was kind of, this is it, and take it or leave it. And now I really do get a sense that there's an openness to listen to stakeholders, to get our feedback and to get our input. And a lot of what we have said collectively since then, I believe, has been incorporated or at least considered in the process that's being proposed. And let's, not be sort of fooled by the fact that there may have been a number of options that could have been on the table. Do you completely separate the two processes? Do you develop a new sort of agency to look at these questions, or do we work together? And I think the best option has actually been adopted, which is great to hear.
Thanks, both of you. I appreciate those comments. Let me start. Maybe we can talk about the timelines. I should say that CADTH has made it clear that at the moment they are proposing that the integration of the CDIAC responsibilities is not going to change the target time frame for a pCODR evaluation, which is approximately 180 days. So do you have any thoughts in terms of your reading of the proposals regarding timelines or the possibility of delays? Louise, I'll get you to start this time and ask Martine after.
Sure. So one of the things that was explained to me is that pCODR will continue, and I hope I have this right, that pCODR will continue to do its normal kind of perk review and before it actually does an algorithm review. And I'm actually entirely in favor of that, because every treatment should be looked at on its own merit based on the formula that pCODR has used, the 4-step formula, deliberative framework. So I'm glad to see that that will remain intact, and we will get a look at the drug on its own merits. And then if it does get either a full or what's much more likely, a conditional approval, subject to conditions worked out at PCPA, then it will move to kind of the algorithm stage. The one thing I would not, and I think that's the right process. Having said that, I would not want the fact that there is that additional step to add any delay to the overall time that CADTH is taking with any review.
Thanks. Martine?
I mean, they're committed to keeping the 180 days, which, it's great because they've actually added more work to what they're doing by including the algorithm. So kudos to them. It would have been great if we could, reduce that time from the patient perspective. Time is of the essence, but, understand that there are some very strong metrics and deliverables and commitments to and transparency to keep to those. So that's That's very, very much welcome. I think the question of the algorithm is going to be a little bit, more problematic, maybe for patient organization to get their heads around, but we can talk about that a bit later.
In fact, that's a good segue into my next question around whether you support this notion of creating a treatment algorithm outlining the place in therapy of the medicine under review. And if yes, what role should patient advocates have in its development?
Do you want me to go, or do you want Louise first?
Yeah, keep starting. Yeah, keep going.
So I think, patients are always looking for a treatment plan. Call it an algorithm, but in their minds is, what's my treatment plan? Where do I start? What's my next treatment, and so forth? That's going to keep me alive and well for the longest possible time. So having a notion that there is a plan ahead is a good one, and that they will have access to it. But having said that, the algorithm that are being proposed by CADTH and CAPCA are based on sort of the clinical evidence that is available at the time for a particular treatment in comparison with other treatments. And we know that that's not always, we don't always have the answers to those questions, because the clinical trials are not done in comparison or in a sequential or way that's going to help us address 100% of the questions of the algorithm. So there has to be flexibility, that's for sure. And patients may not know or be that much involved in the clinical evidence that is relevant to developing these algorithms, but in their minds, an algorithm would be based on where they are in their therapy or their treatment and what they're looking for in terms of potential outcome. Case in point, you've got a patient who's young, who's active, and who is working. Well, if their next sort of ticket number up is a treatment that requires like a 2-hour or 2-day or 3-day infusions, that's not going to be the right treatment for them. So you have to be flexible and understand where the patient is at. And that's where I think the patient input will have the greatest impact when it comes to providing comments on the algorithm.
Thanks, Martine. Louise, do you have any comments on the algorithm, the notion of the algorithm, and where the patient?
Well, I think notionally we already look at sequencing of drugs. Doctors do it, patients do it, probably everybody does it, governments do it. I mean, and in concept, I don't think it's a bad idea. You don't want to use up a drug early that really is best used as a sort of salvage therapy later on, and cut off opportunities. I think we always should be looking at what does the science tell us is the right order of proceeding for treatment, as well as what is appropriate for that particular patient. And those two things are not necessarily the same. Sometimes an algorithm that works on a health population base may not be the appropriate one. I think that's Martine's point, that, you have to look at both. But let's start with the health population base. The key, in my view, to the development of these algorithms is a multi-stakeholder approach to developing them. And obviously, for me at least, expertise by clinicians and researchers who work in the particular area of oncology under consideration is paramount. And so that if that doesn't happen, then I'm certainly not going to be supportive of the process. I also know that patient groups and patients look at sequencing, you call it algorithm sequencing of their drugs, and I really hope that one of the things CADTH will consider, pCODR will consider, is adding a few questions to the submissions that patient groups put in on behalf of patients, asking them if they have any advice or comments or experience with sequencing that might be useful in understanding an algorithm. So I'm in favor of it, but I also would say that while we need good help in developing those algorithms, we also need to ensure that there's monitoring and evaluation on a regular basis, because things are changing so quickly in cancer that what looked like a good algorithm yesterday may not really be the right one today. And as for those folks who, in a sense, fall out of the algorithm, the idiosyncratic cases where what would normally be something very good is just not right for this patient, I really urge CADTH to engage the provinces to develop a case-by-case compassionate access program. I don't mind if it's public, private, or however it's developed, so that those people who just don't fit an otherwise perfectly reasonable algorithm will still get access to treatments.
Thank you both. So let me ask a more pointed question about this, and I'll preface it by reminding people that the algorithm, the potential algorithm, is going to be developed by CADTH. That there'll be questions relating to it that are going to be directed to clinician and patients in the context of their initial input. But the algorithm itself, if I understand correctly, is not going to be presented to the patients and the clinician, the registered clinicians, until after the initial PERC recommendation. At which point they'll have an opportunity to speak to it prior to the development of the final recommendation. So, do you think that that's the right process, or do you think that patients should be involved at a different stage in the process? So, Martine, maybe you can comment first.
Sure. Just recently, CADTH and Health Canada, announced their the scientific advice combined, or the collaboration between the CADTH and Health Canada on the scientific advice that are provided to manufacturers. I personally think that the discussion of an algorithm should happen at that stage much sooner than what they are proposing, so that there's clear understanding of what the unmet needs are and where a new treatment could potentially have a place in therapy based on specific outcomes that would be achieved through the clinical trial and development process. So that's one thing. I know this is not what's being proposed, but I think it should happen much sooner. And patients should be also involved in those discussions in designing or inputting onto the clinical trial process and having those conversations. But at this stage, I think the patient's inclusion of the algorithm, it's actually happening. We've had a couple of submissions that call for submission for a couple of products in the myeloma field, and you could read in the questions that they're asking patients, organizations, what they're trying to decipher and trying to get from patients as to where they feel this new therapy should be placed from the patient's perspective. So although we're not being presented, or maybe we won't be presented with an algorithm, the questions that are being developed for patients and also for clinicians in their input submission are certainly pointing to sort of what is the algorithm that's kind of, sort of coming out of those discussions. So, I think, the better and the sooner we include patients is important, and perhaps we should move the discussion sooner into the process.
Okay, thanks. Okay, so Louise, do you have anything to add on that?
Well, I certainly support everything that Martine has said. I do think we must keep one thing in mind, and that is that these clinicians and researchers are so profoundly busy looking after patients that we're certainly not going to get them looking at a blank slate and developing an algorithm, that way. And so I think that they need, what I recommend is that CADTH work with these clinicians and researchers and ask them when they want to be engaged and how best to engage them efficiently, but to get their best expertise. So I don't think I know the answer, but I think it's a question that needs to be put to those folks.
Thanks. And Louise, actually, you again have led me right into my next question, which was around, any comments with regard to the clinician input elements of the proposal. So just again to remind folks, the individual clinicians registered are able to sort of participate in the process the same way that patients are. Clinicians are also engaged in the clinical review panel, so they're selected by CADTH and contracted to review the data and develop the clinical report that goes to PERC. So there's a couple or three or whatever the number is who are involved in that at that level, and then CADTH's proposal suggests that in certain cases expert panels could be created, ad hoc expert panels could be created to sort of get at what I think, Louise, you were just talking about. And in other cases, a survey could be sent out to clinicians who are focused on this area or this particular area of cancer. So that's how they're currently evaluating. I just wanted to get a sense of whether you think that those are the right solutions, or are there other suggestions? So yeah, maybe I'll start again. Louise, you can start, and I'll get Martine to comment.
I don't really know if I have more to add at this point on this subject, actually. Martine, maybe you can add some stuff here.
Sure. I think it's not clear in the process as described today by CADTH if the physicians who are participating in the ad hoc sort of committee or participating in the survey that will be sent out by CADTH or can participate in the clinician input survey that happens after the submission is made, just at the same time as patient organization are putting their survey. So you may have duplication. Not sure how that's going to be handled by pCODR, and something that I have raised to their attention, and I think they will be looking at this because you certainly don't want to overburden or get physician burnout. I think that this new process obviously calls for more input from physicians or physicians to be more involved in the process, and it makes sense because if they need these drugs, and if they're not happy with the outcome of the pCODR recommendations, well, they should have their say, and they should sort of provide their clinician expertise as to where these drugs should fit in the sequencing. Therefore, it's important for them to be involved. And then to Louise's point, they're very busy. And usually you will get the same physicians coming back and providing input. So it's going to be important to educate physicians about the importance of this new change, their roles, as well as making sure that they stay and more become engaged. And that's going to be a tough rodeo for them to do.
Right. Okay, so thank you both for those comments. I have a couple more quick questions for you, and then I'm going to move to the question period. So, folks, this is your opportunity to address any questions to me or to Louise or Martine. So let me ask you this. Do you think, after looking at this, that the proposal improves the accountability and transparency of the current pCODR review process? And does it meet patient needs better? So Martine, do you want to start?
On the surface, I would say yes, but I think the proof is in the pudding, and we have to go through a few iterations to see if it really does.
Great, Louise.
Well, I don't see how it could not improve it, since what we had before was no transparency and no patient or anybody else engagement that we knew. So, I guess that's a kind of a facetious answer, but of course it's an improvement. I want to reiterate what I said at the beginning. Having worked in this area for, thank you, not mentioning how many exactly years, Gerry, but many. I know that the best laid plans of mice and men can go astray, and so the important thing is that we can recognize that what happens initially may not be perfect, may not be even acceptable to us as a final product, but that if we can have an agreement kind of as stakeholders that we're going to help and work together in a productive way, constructive way, that as long as we're getting the opportunity to be constructive and to have consultations and collaborate, let's keep working the process until we get it to a place that is reasonable and works well for all the stakeholders involved.
Thanks both. I have one more question for you, and then we'll move to the public Q&A. So, thinking about this process, the consultations, the changes to pCODR's review, do you think that this represents an opportunity to improve CADTH's, the review process governance more generally? Is there a leverage point here? Louise, I'll get you to start.
That's a tough question. Well, I think under the new mandate of CADTH, which is moving from assessment to management, this is certainly part of the overall management of treatments in the system. So it certainly fits with the new mandate. And I am a big believer in as few separate bureaucracies as possible, because then people either aren't talking to each other, and so they're not getting the best synergistic information. And also it saves, hopefully, administration time and cost.
Martine?
Louise could not have said it better. I think that it is definitely in line with where we're seeing health technology assessment go. It links appropriate use of medication linked to real world evidence. And Louise, you mentioned having some metrics and some reassessment isn't going to be really important. And it fits well with the sort of overall management approach, HTA management approach that CADTH is taking. But they will have to actually put that into action, and that still is, something that is not, I wouldn't say well defined, but is the how where this is going to be done is still unclear.
Thank you both. I think that you've given the folks out there who are developing their own responses to the consultation some food for thought, and it's been a very, very insightful question period with you both. So thank you for your feedback and your input. I'm going to move into a couple of questions. I have a few questions so far. If there are others, please pass them along, but I can address the first one quite readily. The first question was, is Quebec part of PERC and the PAG, the Provincial Advisory Group? And the answer is no. Quebec has its own HTA process through INES. It's very similar but distinct from what CADTH does. However, to be clear, Quebec is part of the PCPA process. So when HTA recommendations, either from pCODR, from CDR, or from INES, are presented or developed and recommendations published, those go to PCPA, and they're all negotiated by the same group. So I hope that clarifies that question. There was another question that was, are you aware if the private payers will be engaged in the CADTH and CDIAC update? And I don't know the answer to that question. That's a question probably best put to CADTH. I can tell you that the consultations have not made reference to the private payers, and pCODR is not a process that is designed to meet the needs of the private payers. They have their own HTA processes in place, or product evaluation processes in place. So I don't think so, but as I say, that's probably better answered by the folks at CADTH. Next question was a little bit more detailed. So once the transition from CAPCA to CADTH is complete, the CDIAC transition, what are the chances that CADTH would be prepared to release publicly previous versions of algorithms that have been recommended through the CDIAC process, like so algorithms for products that are currently under review or who have already been reviewed? Again, this question might be better asked to CADTH, but the questioner is asking Louise and Martine if they had any thoughts around that. So just a question that you guys might want to take a crack at.
It's Louise. I don't have any opinion about that.
I mean, I think it would be great if they would. Is there, a way or method that they would release those algorithms? I don't know. I think we can look at, how drugs are funded in different provinces, and that could be an answer to the question.
Okay, thanks. Next question is around reassessments of algorithms. So there doesn't appear to be in the consultation or the proposal from the consultation any sort of discussion around reassessments of the algorithms. Do you think that that there should be, and is there a role for patients in prompting that, participating in it? Martine, I'll let you to start.
I would say yes, yes, and yes. There has to be a reassessment. Obviously, as new evidence is uncovered, new clinical trials or databases are created, and analysis of data from these databases, and in the context of the real world evidence, there has to be a constant loop back to evaluate if the algorithm is still relevant or not, or if there needs to be more exceptions, or are we actually having the right algorithm? And algorithm also needs to translate into sort of reimbursement and access for these drugs. I think one thing we didn't talk about was what happens after the algorithm is sort of nailed down. You've got your pCODR recommendation, and it goes to PCPA. Does the algorithm then become the basis for negotiation between the manufacturer and the provinces? Those two have to be lock in step so that we can reevaluate these algorithms, because if what's being reimbursed is different, then we have a big problem.
Right on. Louise?
I think in my remarks I mentioned, and I'm happy to repeat, that it is mandatory in my view that there be a process for monitoring and evaluation and reevaluation of algorithms. And I think we all have an opportunity to respond to CADTH's survey on their CDIAC proposal. And I would urge all of you to do so, and I would urge all of you to mention that as one of the things that patients consider to be mandatory, and also that it is mandatory that all relevant stakeholders, including patients, are engaged in the development, implementation, monitoring, and reevaluation all the way along the piece.
Thank you, Louise. I think that's a great way to pull this all together. We don't have any further questions, so
Gerry, if I could just make one comment. I think, and this is my own personal observation, that this new process and how the patient input will be developed is going to create more work for patient organization, because the questions are going to be so specific for a particular treatment. we are going to have to readjust the way we go and survey our patient population according to those questions. So it's not something we can prepare a lot in advance. We have to wait till we see those questions to go out and survey. And we don't have a lot of time. So one of the things that I would like to see is more time giving to patient organization to do these surveys so that we can provide some good quality feedback, given the, and have the right amount of time to do this. So that's just my personal observation after reviewing the process.
And can I jump on and say, in addition to that, or as an augment to that, one of the important things is the opportunity for the patient groups to get hooked up with patients who are in trials as early as humanly possible, so that we can start to know what's going on with them and what they're experiencing long before the submission date comes around. And so I really urge everybody to urge clinical trial researchers and clinicians to work with us and understand, without, of course, breaching anybody's confidentiality, and of course with informed consent, to engage us with the patients that they're dealing with who are on these drugs as early as possible.
Yeah, those are great messages. Thank you very much, both of you, for participating today. As I say, I think we've given, I hope, the groups that are preparing responses to the consultation a lot of meat to work with as you prepare your input. So hopefully it's been useful and helpful in doing so. Remember that the deadline is March 28th, 2 weeks from now. And thank you everybody for going through this process with us today. It's, as I say, I think it's been an insightful conversation. So I appreciate the opportunity. I really appreciate Louise and Martine's participation and contribution. And I guess at this stage, I'll pass it back to Allison for close. So